Hello and welcome to another edition of the Lympha Press Educational Webinar Series. This is one we have been so excited about because for many years, Lympha Press has had a wonderful relationship with the Campisi Clinic in Genoa, Italy. Now, I did want us to record from Genoa, but they instead said, let's do this via Zoom, right, Deborah? I am with Deborah Gross from Lympha Press. For Mega Affect, she is the Director of Clinical Marketing, and she has been an integral part of the relationship with the Campisi Clinic. And our guest today, first, is Elena Parodi. She is a therapist that has really wonderful information to share with us. And Dr. Campisi, who we have promoted, is in surgery right now. And we know, and we are very hopeful, all of our fingers and our toes are crossed that he will be able to join us. But in the meantime, let us know that you are here. Tell us your names in chat, where you're logging in from. We will be handling questions and answers at the end of the presentation, but we encourage chat throughout. We appreciate you taking time out of your busy day to be with us today. And yes, this is being recorded. We will definitely make the presentation available to everybody who has registered, and ultimately it will be on the Lympha Press YouTube channel and on our website. I am Brenda Viola. I am honored to welcome all of you today to this presentation, Prehab for Lymphatic Microsurgery, the Campisi Method. And without further ado, Deborah and I are going to disappear and we're going to let Elena Parodi take the floor. Thank you, Elena, for being here. And please do walk us through your presentation.
Thank you so much, Brenda. Hello to everyone. Good morning in America. In Italy is the 7 p.m. so it's evening. And it's a pleasure to me stay here with you. Thank you so much in advance. I'm Elena Parodi, physiotherapist from Genoa, Italy. Today, I want to present you an experiment I participated in conducting in Campisi Clinic. Campisi Clinic, as we all know, is specialized in the treatment of lymphatic disease. Founded in 1973 by Professor Corradino Campisi, a surgeon who treated thousands of patients with lymphedema through the MLVA surgical technique. The work of the study, so the prehab for lymphatic microsurgery, the Campisi Clinic, is a work conducted by a team comprising Professor Campisi, Dr. Campisi, a nurse, podologist, myself, and other physiotherapists of the clinic. As we all know, the daily therapy or CDT needs for our patients with lymphedema constitute a great cost in terms of money and time. This awoke us to the need of creating or finding a new way or new combinations of therapies to improve the treatment of lymphedema. This study tries to answer this question because the goal of the study is to assess the impact of intermittent pneumatic compression, or IPC, on volume reduction of lymphedema affecting lower extremities of adult patients when added to decongestive therapy, or DT, as preparation for microsurgery. So, multiple lymphatic venous anastomosis, MLVA, is a procedure featuring a bypass at the site of the obstruction by performing a lymphatic venous shunt. It consists in one single skin incision in the groin area, very little, linking the lymphatic system to the venous system. To confirm the good results of surgery, an Indo-Shannon green test or ICG test is performed. Physiotherapy is fundamental before and after surgery to reduce the amount of the liquid inside the tissue, avoiding or reducing the risk of overloading the new bypass once in place. I'm sure that Corrado can explain very better this procedure after me. In this protocol, conservative therapy, so the physiotherapy and the surgery are deeply linked and work together for cohesive and more efficient treatment. It's very, very important. So, what is it, IPC? In February 2021, we decided to start testing a new device in combination with traditional decongestive therapy. IPC, as you can see from the image, is a wearable tool made up of 24 air chambers linked to an air compressor. IPC system provides a sequence therapy based on the principles of manual lymph drainage, applying an initial proximal pressure over the trunk, preparing the lymph vessels of the thoracic inguinal region to receive lymph from distal areas. After this, compression is applied to the distal areas, moving from distal to the proximal region with a sequential movement. Its pressure range goes from 20 to 19 milliliters of mercury. Okay. The study began with a visit by a medical specialist, like Corrado and Professor Campisi, and was followed by a lymphoscintigraphy exam. These two steps were fundamental to evaluate the candidacy of the MLVA surgery. The first step consisted in creating the two groups, experimental group and the control group. Each group was made up by 25 patients. Experimental group did IPC added to decongestive therapy, so the traditional therapy. And the control group did only decongestive therapy, so the traditional therapy. Step 4 was comparing volumetric measurements of the legs at the beginning and at the end of therapy. These measurements were taken with a pyrometer. More specifically, the medical visit consisted in the evaluation of patients' medical histories, their health condition, and lymphedema staging, as shown in the table. Additionally, a Doppler ultrasound was necessary to rule out venous involvement in the swelling, which would exclude the patient from the study. Step 2 consists in the lymphoscintigraphy. Lymphoscintigraphy was prescribed for each patient to assess transport index and have an image of the lymphatic flow. PI is a quantitative method to evaluate the circulatory capacity of the lymphatic system. A TI score under 9 indicates normal status. A TA greater than 9 indicates a pathological status. The picture, as you can see in the PowerPoint, is a lymphoscintigraphy of a female patient's leg, one presenting normal and one with a high TI score. The contrast liquid indicates lymph is seen as the blackened area in the picture. The right leg presents a TI score of 27, which is very, very high. And this picture shows the derma flow effect. So big areas with color in black. Before undergoing lymphoscintigraphy, patients must do 7 to 10 days of therapy to reduce the derma flow phenomena as much as possible, which ensure a better image. So the therapy of the two groups. Let's look at the therapy of the two groups. The treatment period ranged from 3 weeks to 3 months. But all patients did 14 to 21 days of consecutive therapy before the surgery. So the experimental group did IPC added to the decongestive therapy. IPC was performed every day for 2 hours with a pressure between 45 to 55 milliliters of mercury. The multi-layer bandage and skin care was applied every 48 hours for both groups. And the lymphatic drainage was performed every 48 hours before application of multi-layer bandage. Also, we recommend patients do soft aerobic exercise like fast walking or cycling for 20 minutes in order to move their leg and activate the muscle pump, which naturally, as you know, activates the circulator of the lymph, the circulation of the lymph. Okay. For each patient, volumetric measurements were taken at the beginning and at the end of treatment with optoelectrical pyrometer, as you can see in the image. On the image on the left, there is a software of pyrometer, and on the right there is the hardware of pyrometer. We favor use of pyrometer to take measurements instead of tape measure, as it is acknowledged by the literature to be a method of measurement that guarantees high reliability, both inter-rater and inter-rater operator. Okay, the two groups. In this slide, you can see the general characteristics of the patients. We made a statistical analysis to make sure that the two groups didn't have any significant starting difference. As you can see from the p-value, we didn't find any relevant difference. So the two groups are homogeneous. Okay, the results. This slide reports the result of the study. We considered the percentage decrease of volume of the lymph decreased in both groups. The percentage volume decrease for each group is presented with error bar representing one error standard. Some of the observation came from different legs of the same patient and shall not be considered independent. So we used mixed effect modeling for the statistical analysis. The control group reduced volume on average by 5%, while the experimental group on average by 11.7%. The 6.7 point difference is statistically significant, so percentage change volume in final lymph volume was calculated with a formula in the slide. We observed that the elapsed time from the beginning and to the end of treatment is relevant. From the graph, we can see that the maximum volume loss was achieved for both groups on the 44th calendar days inside the treatment. On day 44 of treatment, the control group had decreased by 6.6% on average, whereas the treatment group had decreased by 12.8%. The lapse time of treatment ranged from 3 weeks to 3 months from the beginning. And measurements were taken with a time frame of 10 days to 3 months. The reason being that depending on the treatment course prescribed by the doctor, some patients had DT for 1 week every month for 3 months, while others followed a more intensive treatment lasting 2 or 3 weeks. The final measurement was taken after a minimum of 12 consecutive days of therapy in preparation for surgery. Hi, Corrado. This point should be investigated through future studies to evaluate the best duration of the treatment. And it is possible to state that use the IPC through the Lympha Press Optimal Plus device in combination with other DT constitute a better preparation for MLVA surgery than traditional therapies, as it has proven to generate a great decrease in proportional volume in the experimental group. And this is this patient that you can see in the picture is the same patient that you saw in the lithoscintigraphy. And this photo was taken before the surgery. So it's a good result for the physiotherapy in preparation of the MLVA surgery. Thank you so much for attention.
Elena, that was really amazing. We've got some questions that have come in from the audience, but thank you so much. You were directly involved with this, so I know that you can speak to this question from Josh Thatch. Josh, we're so glad that you are with us. He asks, the conservative management control group received MLD every 48 hours. How long was MLD performed, and was it anterior and posterior chains? And if I need to rephrase that, and by the way, Deborah Gross, if you want to jump back on as well, because I know that you were involved with this. And I do want to also say, while you consider that, Elena, we have people from all over the world on this webinar. We have people from all over the United States, everywhere from Minnesota to Colorado. We have Canada, we have Florida, New York, New Jersey, California. How wonderful that you're all with us. We have Italy with us as well. And so Josh's question is about the MLD. Was it anterior and posterior? And Dr. Campisi, it's wonderful to see you.
Thank you. I'm sorry. I just finished. I'm in the clinic. I just finished OR. I had 3 big cases of microsurgery today, and it was a kind of long day and a big liposuction.
Oh,
so
wow.
I'm sorry, Elena spoke before me, but I'm fully available now, all for you. I'm sorry for the delay, but it was due to my surgeries.
Dr. Campisi, you do not have to apologize. Taking care of your patients is the most important thing, and our audience is delighted that you are with us and you were able to join. Elena did an amazing job walking through the study and the results, showing that intermittent pneumatic compression, the Lympha Press, showed real volume reduction in the limbs. We have a question from the audience regarding manual lymph drainage. The conservative management control group received MLD every 48 hours. One of our attendees is questioning, how long was the MLD performed, and was it anterior and posterior chains?
Okay, Elena, I answer or you want to answer?
Yes, please, whoever wants
Okay.
to answer.
Yeah,
So
can answer.
there are different kind of, to be precise, the manual lymphatic drainage depends on the pathology. There have been many studies that show that when you do manual lymphatic drainage, if you have, for example, a monolateral leg lymphedema or a monolateral arm lymphedema, to stimulate also the contralateral arm is important. So there are many studies now that are coming out also using the ICG, the endosomin green method, the microlymphography, to check the lymphatic pathways. So, for example, in the lower limb, there are some pathways that are not the usual one, not only the popliteal ones, not only the inguinal ones, but also stimulating the contralateral lower limb, stimulating the back, stimulating also other lymph nodes in the body is very important. So now we have to see also, we have to understand the manual lymphatic drainage was applied depending on the pathology of the patients, if it was a primary lymphedema or a secondary lymphedema, if it was a monolateral lymphedema, a bilateral lymphedema, and if it was a lower limb lymphedema, if this lymphedema was if it was also involving the lower abdomen and the genital area. So different kind of manual lymphatic drainage, but let's say that the minimal length goes from 40-45 minutes to 1 hour. But the most important thing that we have seen is that when we thought of applying IPC perioperatively, we have seen that in the past that there were no studies that were applied on this. And I have a very good also update for who is following us today, that the paper regarding the study, the official paper regarding the study that Elena just presented is coming out very soon, will be published soon in official journal of the International Society of Lymphology. And the journal is Lymphology. It is the official journal of the ISL, International Society of Lymphology. And as you know, I will be the president of the World Congress that will be held in Genoa next September from 11 to 15. Lympha Press will be present as one of the main sponsors, and of course all the attendants to this webinar are invited to join us, and during my presentation I will give you some more details if you want to also go on the website and see all the possibilities if somebody wants to participate. Fantastic. So, but I think this is the answer to the questions. Manual lymphatic drainage, there are different methods, but there are the standard ones, but it depends on the type of lymphedema, okay, that we have seen.
Thank you so much for answering that question. Did you want to add anything, Elena, before I go to the other questions? And I see your hand too, Deborah.
Yeah, I just wanted to, perhaps we can describe the conservative therapy. The patients also had bandaging, lymphatic bandaging as part of their conservative therapy. So you had a control group that had lymphatic drainage, and you had a control group that had, the control group had lymphatic drainage and bandaging, and the treatment group had manual lymph drainage, lymphatic bandaging, and the Lympha Press added to it. Now, there's some questions about the type of manual lymph drainage, so maybe we should go and we should talk about that a little bit.
Yeah, we did the mechanical lymph drainage through the LPG machine for all patients, because we understand that when we have a lymphedema, hard lymphedema with skin involvement, we can use LPG to have more drainage from distal areas to the proximal area before stimulating the lymph nodes, as you Corrado told. And in advance, we can add manual lymph drainage. And it's very useful for us, the ICG test for the physiotherapist, because we can see where is specifically the stream.
I can make
of
an
the-
example. I can make an example also to let's say fulfill also Deborah's statement and consideration is that ICG is important, but also preoperative lymphoscintigraphy is very important to see where the pathways are. So I make an example. Today I did a surgery on a patient that received IPC and preparation before surgery. So it's a kind of patient that is following the treatment group that we're speaking about today, okay? And this patient is a young woman that received the microsurgery today as second patient of the day, and primary lymphedema, bilateral, she's more or less, she's a nurse in Italy. She's less than 30 years old. Primary lymphedema of both arms and both legs, okay? So 4 limbs affected. The worst situation is in the upper limbs. And today we started from the right one. The right one showed from the lymphoscintigraphy there was a selective impairment of the deep lymphatic circulation, and the superficial lymphatic circulation was normal. When I performed ICG immediately before surgery, the ICG was showing a perfect functioning superficial system. You will see in the pathways going up to the axillary lymph nodes. But the deep lymphatic system was not working at all. And also when we see the ICG, or we can evaluate the lymphoscintigraphy, we can see where the pathways are. So if the therapist is performing a manual lymphatic drainage without knowing the variation of the lymphatic system on an arm or in the leg or anywhere he does manual lymphatic drainage, he may insist in an area in which there are not good vessels or nodes available. So imaging before therapy is always extremely relevant. So this is the surgeon, this is the physician that tells the therapist, look, the ICG shows this, look, the lymphoscintigraphy shows this, so you should focus on these regions. Because you can work on the forearm and there are no lymphatic pathways, because maybe in the patients there are posterior ones. So you can work on the cubital area, no? But maybe nodes are in the other area. So depends on the anatomy, and the anatomy is extremely different, especially in patients with lymphedema that have or a primary lymphedema, so malformations, or a secondary lymphedema with lymph nodal removal or post-traumatic. So manual lymphatic drainage depends, every kind of therapy, even bandaging, or when you touch the patient, depends on where the good vessels are. So this is has to be tailored each patient. So if you do a standard manual lymphatic drainage, it may not be useful, and the patient may tell you, doctor, I have no changes in my lymphedema. So this is very important also.
It is so important. Not everybody is the same. And so the imaging helps to give you a roadmap. Thank you for explaining that, Dr. Campisi. We have more questions in from our audience. Kathleen Lisson, coming to us from San Diego, California, asks,
I know Kathleen.
I know everybody knows Kathleen, and she's also saying everybody needs to come to Italy to the conference.
Kathleen is coming. Kathleen is coming. Kathleen is doing also instructional courses. She's doing lectures, and Kathleen is very, very much involved in the meeting in Genoa. Ciao, Kathleen.
Yes, ciao, Kathleen. We're so glad that you are here. And she asks, do you continue complete decongestive therapy until limb volume plateaus? It's so interesting that there is a larger reduction in limb volume before it plateaus when intermittent pneumatic compression is added. Could you speak to that, Dr. Campisi?
Yeah, I agree. I mean, CDT, we continue that to achieve preoperatively the best volume reduction, but the best scenario before surgery, the best scenario, if possible, is to have no water on the limb before surgery. So no pitting, okay? No pitting means good therapy, okay? No pitting means both before microsurgery, both before liposuction, because if you have a big pitting and you perform liposuction, the surgery is not a good indication, okay? So the goal of applying CDT, manual lymphatic drainage, the use of IPC and other therapies is to reduce as much as possible the quantity of water in the affected limb, okay? After surgery, so with the surgery, what happens with the surgery? When you do microsurgery, then you open channels, okay? You open channels. There is a block somewhere and you open channels. So it is supposed that after you go to the surgery in the best conditions, possibly without water in the limb, then you perform microsurgery, you open channels where it's blocked, and then after surgery, the therapy works even better. The goal after liposuction is that after liposuction, that comes in our protocol after microsurgery, liposuction comes after microsurgery. The goal is to remove the excess solid tissue, so the adipose tissue, the fibrotic tissue, to have a lighter limb and to remove all the inflammatory tissue that is in the affected limb to improve the lymphatic function, okay? But the main goal of the therapy is to have no water in the limb, okay? But if you have a long-standing lymphedema, everyone knows that there are people that have lymphedema for 10, 15, 20 years, and they do not have a huge amount of fibrosis, okay? But there are people that develop fibrosis in 3, 4, 5 months. So it depends also on how fast the disease progresses. So this is also extremely relevant, you know. So you have to analyze every time the cause of the lymphedema, the progression of the lymphedema, the way the lymphedema occurred as well. So every patient is different for sure. So of course we have to standardize protocols, but every patient is different, you know. So some treatments may work, some other treatments may not work, okay? So so it depends on that. So if you are in a good center, of course the therapists, the surgeons, the physicians that are in the center, of course, address the best options for the patients, and they keep the patient followed up, considering which is the progression of the treatment. So we perform perometry, we perform volume measurements, we perform ICG, we perform questionnaires to patients to ask about their pain, to ask about their mobility, to ask about, you know, many parameters. And so we keep following this in time, okay? So this is, I hope to have answered to Kathleen.
I think that you answered that beautifully. And you want to jump in, Deborah, go ahead.
I had a question based on Kathleen's question. Actually, what the study shows is that the plateau that you reach with Lympha Press is different, is significantly different from the plateau that when Lympha Press is added to the treatment is significantly better than the plateau that the treatment reaches only with decongestive therapy.
And I have to say another thing, Deborah. If I'm a surgeon, and just to make you understanding what happens in Genoa, patients stay at least 4 months in my place. Okay, sorry, for weeks, I want to say. So at least 4 weeks. So they come to do intensive 2 weeks before, then they do surgery, then they do 7 to 14 days after. Okay, this is the intensive treatment. So if I would apply only manual lymphatic drainage in the 2 weeks postoperative, okay, I would never have the patients ready for the surgery, okay, so fast. So it's also a matter of time. This is something that has to be said, because patients to achieve those results needs more time, more hours of treatment, and it is also more tiring and sometimes painful, okay? So we have also to consider that, because timing is essential, is a key point.
Yeah, excellent. You know, Kathleen follows up with a question about bilateral treatment. Even if the one limb is having the surgery, do you recommend the bilateral use of?
Always, we treat, for example, this girl, I was speaking about this lady today that received surgery, just an example, because I did surgery a few hours ago on her. So, I mean, she had the 4 limbs affected, okay? So, scintigraphy shows upper limb, superficial system normal, deep system, not there, okay, not there. Lower limbs, deep system normal, superficial system impaired. So it's a different problem, okay? So we have also to understand, there is another important thing to say, because if you have no deep system, but you want to improve the preoperative preparation of the patient for the surgery, you have to work on the superficial system. Of course, you cannot work on the deep system with manual lymphatic drainage. You cannot work on the deep system with IPC. You can work on the deep system only with muscle movement, something, or with surgery. You cannot use stockings or compression in the deep system, okay? You cannot. So to improve to patients that have no deep system, also the function of the superficial ones that can, let's say, supply to the deficiency of the deep one, we need also to, let's say, enhance the superficial one to help the deep one, no? Because they're connected, we know they're connected like the veins, like the venous system. So if we just perform MLD, it's not enough. We have never performed only MLD. Okay, so this is what I think, and this is what I see from my experience. You need much more time, and it takes longer. And I have patients coming from all over Italy, Europe, outside from Europe, patients coming from the States, and I have to give them an answer in a small amount of time, because unless it takes too long, and this is also another key point. Yeah.
Excellent. So Karen Ashforth, Karen, we're so glad you're joining us today on the webinar, asks, what pressure ranges do you recommend for the Lympha Press?
To start, also this depends on the problem that is present, but I would not recommend, I mean, too high pressures, never, and so we start with a low pressures, and then we raise the pressures depending also if the patient has pain, experience some problems, some numbing, or I don't know, it depends also, sometimes it happens. But we don't need to apply too much strong pressure, because, if you apply too much pressure, you may, because you have to understand the anatomy to see also how it works this, okay? So you have 3 levels of lymphatics. There is level 1, we described that, okay? We described that a few years ago. So you have a level 1 that is from the skin to the superficial fascia, okay? Then you have level 2 that is still superficial after, so below the superficial fascia to the deep fascia, okay? For example, in this level in the legs, we have the superficial vein system, okay? Then, so saphenous system is level 2. Then under the fascia, you have the deep system where the muscle is, okay? So if you apply, so when you do IPC, when you do manual lymphatic drainage, you work on these 2 systems, not on the third one, it's too deep, okay? So if the patient has a problem in level, for example, has a problem in level 2, okay, you may apply a stronger pressure to arrive there, okay? But if the patient has a problem in between the skin, the superficial fascia, and you put like 60 millimeters of mercury, is too much. So you have to see where the problem is, like when you choose stockings. When you choose stockings, you have to understand that class 2, class 3, class 4, you have to understand where the problem is. When I do biopsies and send to the surgical pathologist, I say level 1, level 2, level 3. So I want to know the prognostic factors that may affect the choices that I do after surgery with my patients.
So we know, and it's clear, that reducing the fluid prior to surgery is so important. And the protocol after surgery, you have a whole path, a month-long system of preparing your patients for surgery and then post-surgically. Can you just remind us of the protocols that you recommend post-surgery?
Yeah. So post-surgery depends if the patient received a I mean, let's say there are different kind of surgery. The most can be divided between the reconstructive ones and the bulking ones. Reconstructive ones are microsurgery. Microsurgery can be lymphatic-venous surgery, can be lymph nodal transfer as well. We reserve to lymph nodal transfer if we cannot perform lymphatic-venous shunts. But I recently have been to Cleveland Clinic in November, where we met also with some of you. And also, we have, I'm the community of surgeons, and we have to say that other surgeons, they start doing like I do. So, for example, Wei Chen in Cleveland Clinic is not doing any lymph nodal flap if he has the possibility to perform a lymphatic venous shunt. So now today, let's say we speak about lymph nodal flaps, but if it's possible, LV shunts is the best option. Okay. This depends. Then you have the bulking. The bulking can be standard liposuction, can be lymphatic sparing liposuction like I do. And now I do lymphatic sparing liposuction with ultrasound liposuction. It's even more sparing, okay? So it depends which kind of surgery. Protocols depends on the type of surgery you do. After microsurgery, you have to be more careful to push. Because you open a channel at the beginning, if you push too much, you may have liquid deposition in the site of the surgery. So we wait 7 days at least after surgery. We check the site of the surgery, where we don't push a lot. Okay, we push after. We push after 7-10 days, no before surgery. With liposuction, it's very different, because liposuction, if you apply conservative treatments as soon as possible, and we do immediately 2 days after surgery, the recovery from liposuction is much faster, okay? Also, the post-operative possible hematomas, edema, post-surgical improves very, very quickly. But in general, there is a recovery time of 7 to 2 weeks. And after that, we can start to push. If the patient has, for example, a therapist at home, if a patient has other centers where he's followed in his residence, or a patient has a machine, so a mechanical lymph drainage machine like Lympha Press, we suggest to start with the post-op regimen. Post-op regimen, and I don't know if Elena said before I arrived, but we're starting also studying that about the post-op home use of these devices. And also in this case, it depends on the type of lymphedema, the staging, but we suggest at least the first 2-3 months, but up to 6 months, to use the machine, let's say at least from 2 to 3 hours a day. Okay, so starting in the early morning when they wake up, if they have time during lunchtime or the afternoon, and then before going to sleep. Okay, so we suggest at least 2-3 hours of home use of that.
Fantastic.
And this is the answer mainly. Then the follow-up of patient is for us at 1 month, 3 months, 6 months, and 1 year. But if the patient has, like this one of today, lymphedema on the right arm, then left, then leg, then we plan also the other surgeries. So the follow-up is when the patient comes for the other surgeries. But when we treat the patients with multi-site lymphedema, from the therapeutical CDT point of view, we do simultaneously all the parts that are affected. The surgery, we go piece by piece, okay?
Excellent. Thank you so much. Deborah, go ahead. And then I have a question for Elena from Josh Thash about the LPG machine that you spoke about. Is that where you were going, Deborah?
Oh, I was going to ask, just ask something else. How soon, this is always a question that we hear very often, how soon after the surgery would patients be able to use the pneumatic compression, or would you apply it to them in the clinic as part of the post-surgical process?
To me, Deborah?
To both of you, either of you.
Yeah, of course. We apply, but as I said, liposuction immediately, microsurgery, we don't touch for a week. Then after, no problem. But the low pressure, as I said, so especially because when you do surgery, you know under the skin where is the anastomosis. So if you know that anastomosis comes from near the skin to a vein going down, if you push a lot, that is not good, okay? So it depends also on the anatomy of the surgery. So that's why there should be a strong interaction between the surgeon and the therapist, unless it may become a problem, okay? But in general, we wait 7 days for microsurgery, and we do immediately after 2 days when the patient is discharged after liposuction. And I can tell this happens also when we do very big liposuctions, big, I mean, huge quantities, huge liters, you know, I mean, of reduction.
We are so fortunate that we have Dr. Campisi and Elena Parodi with us right now. There's still time to get your questions in if you would like to ask. I see that you answered in text the question regarding LPG. Could you just, for the rest of the audience, explain that for us, Elena?
Sorry,
No problem. I saw that you answered in typing, but
yeah.
for the rest of the audience, could you please speak to the question?
Yeah, we use a LPG machine dermology technique, and it is a device that helps us with manual lymph drainage, because it's very helpful, because there is a negative pressure. So help us with the manual lymph drainage when the patient have hard skin problem, and it's useful because it's good for the preparation also to break the fibrosis, and after the patient can do IPC, and the tissue are more soft, and the lymph can move with addition with the use of IPC during the treatment. And for me, IPC is very useful, even for the preparation for the surgery. It's very useful, and also for in the post-op period, because we can use after 7 days, as we say, Corrado. Yeah. After 7 days, we can start with the treatment with IPC with a lower pressure, like 20-25 milliliters of mercury.
Another important thing is that what we are seeing, so to understand the effect of intermittent pneumatic compression in lymphedema treatment, this is preoperatively, but it's the same sense that we are also, let's say, looking for postoperatively now, and then after months after surgery. Of course, we had to remove some treatments to patients, you know. So, for example, we did the control group, and then we did the IPC group, okay? But we all know, because we had to demonstrate the difference, okay, to see the difference. But to be clear to the audience, we all know that applying multiple things to patients synergically helps to achieve the results faster. So what we're seeing, that IPC works very well. But if you apply manual lymphatic drainage, you apply IPC, you apply intermittent vacuum therapy, you apply shock waves when you have a very strong fibrotic lymphedema, you apply shock waves, you go through liposuction with an arm or a leg that is much softer. So it's a multi therapies are useful for lymphedema. But we have seen that IPC is very important, has a strong role. We had to study it alone to see what happens before surgery. So this is something that has to be clear. So if you have more weapons in your stock, it's much better than having only one, okay? So this is very important, okay, also to say, because also for the same reason I said before, question of timing, fast, you want to give the best results to patients, and you have to give the less invasive treatments to patients. So when we do microsurgery, we pass through from 2 centimeters to maximum 4 centimeters, single skin incision, okay? When we do liposuction, is very small skin incision. We don't even have to put stitches on that. So it's a very minimally invasive surgery, okay? Yeah. So when you perform also all the treatments, you have to know that you cannot only perform manual lymphatic drainage, I think, to patients, because it's so long. I mean, it's too long. I mean, okay. So in our experience, in our clinic, we have different weapons and we apply to patients according to their needs.
I love that you stated that it takes many tools in the toolbox and it takes a team, brilliant surgeons like yourself, researchers, therapists, the Lympha Press. We are all about the same thing, making patients' lives better. And so I love that you underscored that. We have a few more questions if I can impose upon you. After 1 year post-surgery, is using the pump 1 time a day for 1 hour enough to maintain positive results and prevent cellulitis reoccurrence?
Okay, to answer these questions, we have to say that after surgery, after 6 months to 1 year, patients repeat the lymphoscintigraphy. Okay, so they compare the lymphoscintigraphy with they usually don't perform ICG if they don't have to repeat the surgery. But ICG is very selective for the superficial system, okay? If the patient is like a kind of have some depth, you know, you may lose information under 1.5 centimeter. With lymphoscintigraphy, you see everything. Yeah. You take the lymphoscintigraphy, you compare to the previous one, okay? We used to send patients to the same place because still now lymphoscintigraphy has not a standardized protocol, okay? During my world meeting, there will be a session with different countries and nuclear medicine doctors that will share a possible consensus, okay, on a standardized procedure, because some, they just inject in between the fingers or the toes, some inject near the wrist or the ankle, some inject in the palm or down, you know, I mean, so on the plantar region, so it depends on that. But after, to answer, we perform a lymphoscintigraphy. You see the improvement, you see the transport index that has improved or not, and then you decide if the patient is doing great, depends also on the staging. You know, sometimes patients also start to give up the use of the stocking, or maybe for the first 6 months, they use every day, then remove in the night, and they start using a few hours during the day, or when they stay too much in the standing position, or when they do a long flight, or I don't know, I mean, these situations, or when we do strong sport activity, something like that. But in general, the patient, you know, we want the patient to be free, not to be a slave, okay? A slave of the stockings, a slave of everything, a slave of, you know, patient goes to surgeon because want to be free, okay? Yes. Because the patient does not want to be free, yes, just put the stockings and live with the therapist, you know. The surgeon is honestly a chance to get free of this, okay? And if the patient has a very high stage disease, of course, we are not magicians, okay? We cannot change the story, but we can downstage a lot lymphedema. We can reduce the occurrence of infections, and we can also make a patient's life better, okay? Better in terms of quality of life, of progression of the disease. So to answer, you have to consider the staging, the story. So I don't say 1 hour after 1 year for everybody, because it's not true. Okay, so I would say patients come to me and say, doctor, I feel fine, I feel good. I say, okay, you can start to give up the stocking. We go from class 3 to class 2, we see, you know, and patients say, no, doctor, I mean, I'm fine like that because I feel good, but with the stocking, I feel better. So I want to keep it. Okay, some say this. Some, they say, oh my gosh, doctor, I cannot stand with stockings anymore. Now I feel good, so I want to stop the stockings. Some of them say, okay, I do therapy with IPC at home and I'm so happy. I do 3 hours a day. I love because I do smart working, okay? Some of them, they don't need, and so maybe they do 1 hour a day or they do 1 hour a day, I mean, 3 times a week. Yeah. So depends on the situation, but I would keep always this, say, small weapon with you. So if you need, some patients, for example, they bring the machine is very comfortable also to bring for journeys, okay? Yeah. So there are patients that, a patient that I did surgery recently from Italy, she left from Hong Kong, okay? And she brought the machine to Hong Kong, okay? So, I mean, it depends also on the situation, but I would say that the main objective is that to do an intensive phase of treatments and surgeries if needed, and to make the patient, let's say, smelling freedom as fast as possible, you know.
Yes. That's the point. That's what's so exciting about offering a product that people can use in the comfort of their home so that they can make their own lives better and take their therapy with them, and they can talk on the phone and play on their computer, and they're still living life, but they're getting better and managing their conditions. So that's one of the gratifying things about working for Lympha Press, is that we can offer that to people. Thank you for speaking to that. Elena, when you were talking about all the different tools in the toolbox, there was a word you used, shock therapy, and Sandy Hoagie would like to know what you meant by that. Could you speak to that, or Dr. Campisi? She's familiar with vibration and compression, but the word shock was a little shocking for her.
Shock waves are very good. Shock waves are so different. I don't want to become technical now, but let's say that we use them a lot, and I can say 100% of patients, they want them. I mean, we use it every 2 days, every 48 hours. And I mean, they're so good before surgery and after surgery. And we have a special device that is only for medical use. It's not like for estheticians. It's only medical use. It's very strong, so to be a learning curve to use that, you know. But yes, shockwave is part of our therapies. Yes, but for example, also exercise. We have a very big gym in our place. We are partners with Technogym. Is now one of the biggest wellness company in the world. It's Italian. And is really the story of technology is like the story of Steve Jobs and Jeff Bezos, you know, these kind of stories, you know. And so you don't know, I mean, the way this guy did like an empire is unbelievable. And they produce a line of health, okay. And we did a strong partnership years ago, and we now are doing something very special that will be coming also during the World Congress. So exercise, patients arrives, exercise seems like gym, really gym, sweating, okay, exercise. Then exercise goes for manual lymphatic drainage, then does eventually this LPG that Elena was speaking, then bandaging, then Lympha Press, then other treatments all together. So this keeps the patients busy for 4 hours a day. And so, I mean, in our clinic, we can host up to, I mean, we can host up to 37 patients every hour. So it's a huge number that is turning in the different therapies. And so everyone is more than welcome when if you want to come to Genoa to see how it works, to see.
I think we all want to buy tickets, Dr. Campisi. We're all coming. We all want to come out and see you. And we're also excited about the World Congress coming up. We're going to take one more question, and then I want to yield the floor for any final comments from Elena and you, Dr. Campisi. Josh Thatch wants to know, is the no touching for a week the same for both bypass and VLNT? Some of his local surgeons have different protocols for each, with the VLNT taking longer to heal before the pressure is applied.
Yeah, so VLNT takes much longer. This is the answer. And also another answer for this is that where the VLT is, insetted, okay? So you inset the lymph nodes near the wrist, you inset the lymph nodes near the ankle, it's longer, okay? Because you have less depth. So if you push there, you may affect the flap, okay? Venous return, arterial blood flow, so you don't have to push a flap, okay? The flap has to be there. If you put a flap, let's say deeply, so there are some other insets that are in the, I don't know if I'm becoming kind of technical, but there is the medial sural artery that is more or less behind the knee, near the popliteal region, okay? In the inset there is deeper, so you may work on the leg easier before. If the inset is in the groin, you may work in the leg before. So it depends where the inset of the flap is. But in general, lymphatic LV is like 7 days just to be okay. I mean, it can be less, but 7 days because we don't want to push. Lymph nodal flaps takes longer. Usually they start therapy longer after, so it takes more or less 3 to 4 weeks. Yeah, but depends on where the inset is. Yes.
Thank you so much for that answer. And Sandy Hoagie snuck one last question in. We've talked about all the different tools, but do you have any nutritional info that might be helpful to our audience?
Nutritional. Yeah, I mean, there are, this is a word like, we will speak a lot about nutrition during my meeting also. We'll speak about tissue engineering. There is also a huge chapter about tissue engineering now, because we also use a lot of scaffolds, to enhance the lymphatic systems. I use a lot of also in kids, okay? But so the question is regarding, this, I would say that, so the precise question is?
About nutrition. Do you have any nutrition?
So nutrition, so in general, you mean general?
Yeah.
So what has come out recently is that from the nutritional point of view, there was a kind of confusion and not a lot of studies. Somebody was saying, okay, some kind of diets, low-fat diets, because when you have a primary lymphedema, sometimes you have also some problems with the fat, with the cailiferous vessels in the bowel, no? So this is also a point. Some patients have some low albuminemia, they have some protein-losing enteropathy, so some kind of immunodeficiency, So depends on that. That's why they develop infections, not only because lymph is prone to bacteria, but because they have low immunity, okay? So, but except from that, nutritional point of view has been so much confused, and some others were proposing, okay, let's do a high protein diet. It's not correct also that, because a high protein diet makes the lymphedema harder, okay, harder. And so let's say that now they're coming out a lot of new studies that coming out about the protocols for some kinds of ketogenic diets in lymphedema that should work the most. So I know that now, I've been applying this also in my patients, and I would say that the best that is working is ketogenic diet, low carb, but not high protein, okay? So a good compensation between protein and fat depends if it's a woman, depends if it's a man, depends if he does or she does physical activity or not. So there are many, also the age, so the caloric daily consumption, the body mass analysis. So we have a device in our clinic in which we calculate the different body mass percentage. So we know the patient has a percentage of fat, and we know precisely the content of the fat of the thigh, near the knee and near the lower leg. We know the intracellular or extracellular water component. Okay, so we work on that, no? And there are very specific devices now that help you to do that. But so far I would answer ketogenic diets, some kind of ketogenic diets, they work very well. There is not a huge literature on this now, but studies and proposals are coming out more and more often in the last 1-2 years. So I'm very confident that in the next years we'll have something more, let's say standardized about this.
A lot of physicians prescribe diuretics when they put more protein.
Yeah, this is something that I want to say. Diuretics are really bad for lymphedema, especially if you give, let's say, loop diuretics also so bad. We may use, we use sometimes potassium sparing diuretics. The only ones that we use for lymphedema. Middle of the morning or middle of the afternoon is potassium sparing. We, of course, tolerate diuretics if a patient takes diuretics not for lymphedema. So if he has a cardiac insufficiency or something else like that and needs to take diuretics, for example, loop diuretics for the cardiovascular pathology, of course, we cannot say anything. We may suggest that some, for example, calcium antagonists are so bad for lymphedema as well, no? So we may interact with the physician and say, okay, is that the only therapy you can, let's say, give to the patient? We may adjust the therapy also with other drugs like ACE inhibitors, with some small diuretics to avoid the patient to worsen the lymphedema. So we can also see that, you know, but yeah, in general, if the patient is not taking diuretic, we just suggest the potassium sparing when the pressure levels is sufficient. If the patient has low blood pressure, we don't prescribe potassium sparing diuretics.
Thank you for that answer. And we have already taken more time than we probably should, but I first want to say, Deborah Gross, thank you for being here today. You were a real important part of pulling together this very important study. Do you have any parting words before I also give the floor to Elena and Dr. Campisi?
Thanks. I think it's really an amazing study, and we can understand from it also about treatments for patients who are not getting lymphedema surgery, because it just shows how much pneumatic compression adds to a good program of decongestive therapy. It contributes a lot. It can contribute to a lot of additional volume reduction that the patient can experience. So I think that that's another important takeaway from presentation today, not just for lymphedema surgery, but just in terms of the treatment in general.
Excellent. Thank you so much, Deborah.
Yeah, for sure. Yeah, for sure. And I mean, we can apply this also to patients that, for example, they do not maybe, let's say, there are not indications for surgery. Patients like that are over 65, 70 years old, you know, for example, patients with ulcers. So of course this is
BMI, etc.
high BMI. So that there are different applications that so I'm a surgeon, I speak from my side, but the applications are in general very wide. Of course, what I would like to say before we close that I am available if there are other questions or questions that were not answered. If you send me a memo in my email about the questions that may have been raised and not answered so far, I'm available to do with some delay, but I will answer. And then second, that you are all invited to the World Meeting in Genoa. If you just Google ISL 2023 lymphology.com, you can go to the website. There are the different options. You can see the program. Also, the social program is very nice. The gala dinner would be, the opening ceremony will be fantastic, and the gala dinner will be in an old ancient villa in with the heart of Genoa, a gorgeous place with.
I'm swooning, Dr. Campisi. I'm swooning. I want to go to the gala in the mansion. Absolutely. Sorry, everybody. I had to just say that. That is going to be amazing. But even more so is the great hope and the work you're doing at the Campisi Clinic to continue to investigate, and you're on the cutting edge of what's happening in the worlds of lymphedema and helping patients. We are so, we sort of have a rock star thing going on here where everybody in the audience is so grateful for your time and Elena's time today. And I didn't mean to cut you off there. Continue. Is there anything else you want to say?
No, I want to know. Thank you. I mean, the honor is reciprocal because it's an honor also for me and Elena to be invited by the USA community to speak about this. And if there will be other occasions to widespread this knowledge in USA or other countries in which you, of course, are interested to organize such webinars, I will always be available to do that. And I'm happy that Elena did this when she came in USA in last November. It was her first experience in the States, and she was kind of, let's say, emotional about that. And it's nice that she keep going on this, and I let her being completely free of having new ideas and of course, let's say, ideas of what to do, because I'm always trying to empower young people. And I'm not so old, but I am, let's say, older than Elena. And regarding the meeting in Genoa, I am very happy. If you need any more details, I'm available. And so it will be a fantastic meeting. A lot of very important sponsors are also participating, not only regarding medicine, but other sponsors that are not medical sponsors that are very much interested, you know, in our world. Such as Technogene, the wellness company that is coming. And the program is very nice. I hope to have more than 1,000 people there, because we are planning to host, now the plan is to host 1.5K people, you know. So we see if in the end we'll reach that number, but we have plenty of space, and all the organization has been done for this, to have the biggest meeting of lymphology ever done, hopefully, you know, and also help the society, the International Society of Lymphology, also to renovate, you know, also with younger people, plastic surgeons, and all the other community, and to increase the interest that is mainly focused on patient state of health. So now it's impossible. Then when I do a first-time consultation in 2023, a patient comes to myself, say, "Doctor, nobody knew about my lymphedema, nobody knew about my lipedema. I've been searching for 4, 5, 7 years. They said I had to live with that. okay? It's not possible now in 2020, okay? It's really not possible. So it's something that makes me getting kind of mad when I hear these things, because I say, okay, I mean, we should improve the information. We should improve the way patients easily can access to treatments and can understand at least what they should do in every country, not only in Europe, in USA, in other countries, you know, when the lymphedema can be pandemic also, like India, you know, so, or some places in Africa. So, I mean, in general, such events like webinars or ideas like today are very useful, build and let's say inform small communities, 50, 100 people each time, and spend time together to grow up a network and a good community that can work together.
It is an honor to work with you and the Campisi Clinic. We equally get mad when people aren't getting the help they need, and we are honored to be a part of the solution. I want to thank our entire audience for showing up today from all over the country, in the United States and Canada and the world. Lympha Press is an international company. We have been helping people with lymphedema for over 40 years, and I think it's 37 countries. We are an international solution. We love partnering with therapists. We believe in making life better. And I know that my life was enriched today by having this invigorating conversation. Thank you, Elena, Dr. Campisi.
Thank you so much.
And to all the audience, thank you for tuning in. You will each receive the link to the replay. We will also send you the link to find out more about the International Congress, because we want it to be the most successful ever. And with that, everyone, have a wonderful day.
Thank you. Now I go back to my patients to see if they're fine.
Thank you, Dr. Campisi. Goodbye, everyone.
Thank you so much.